introduce my colleague, Cricket Mitchell. Cricket is a clinical research psychologist and a senior associate with CiMH, and her areas of expertise are research design and methodology, program evaluation, behavioral medicine, and cognitive behavioral intervention. So, Cricket.
All right, good morning, everyone. Can you hear me from here? Do I need to move this? If you can hear me, we're good. Is that better? Yeah. I'm short, right? All right, so let me just find my slides, because I have to apologize I didn't do this in advance, but it shouldn't take me too long. Oh, here we go. Excellent. I think I can see better without those. Except I can't see that. Oh, these decision points. All right, and I brought a clicker. So, good morning. It's a pleasure to be here with everyone. There are a few faces in the room that I recognize and some people that I met before, a few new folks I've met this morning, and I look forward to meeting the rest of you, ideally, throughout the day. I also have to say that it's really exciting and encouraging to see such a full room on a Saturday when the topic is data. I love data. I live data. But not everybody enjoys it. Most people have their eyes glaze over, as Jane said. So I'm just going to spend a short amount of time, and I'm going to try to cover some very basic concepts. I could spend all day talking to you about program evaluation basics. I can build a 6-month course on program evaluation basics. But I've decided to focus in on a few key points and just a couple of key concepts that I think will set a foundation for looking at the data in the notebooks that you're going to be working with throughout the day, and then taking back to your counties and working with forward. My first point is that program evaluation doesn't have to be complicated. It's not necessary to hire an evaluator, although it can be very beneficial. It's not necessary to do fancy statistics, although they definitely serve a function. We can look at data that already exists within our counties, some very basic ways of looking at data, and really pull that together with what we know about our communities to tell a comprehensive story. We're going to look at some different ways in which data can be presented and some caveats about looking at data, some cautions, some limitations, some things to keep in mind as you're looking at data representations. And we know that data is critical. It's necessary, but it's not sufficient. And we'll talk about some of the contextual factors that are important in making interpretations, drawing conclusions, making decisions about data. So that context is critical. So we're going to start with just a basic definition. The bottom line, I'm not going to read my entire slides. I'm just going to leave it up to you to be able to read the content. But the bottom line is that we're talking about collecting data in a very systematic fashion. Sometimes we have the benefit of those data already being collected for us. For example, Mike Reiter is going to talk later this afternoon about data collected by the EQRO. That's already available to you. You might also choose to embark on new data collection. But we're systematically gathering data or making use of existing data to drive our decisions, to drive decision-making around policies, funding, not only how funding gets distributed, but making decisions about whether or not those funding allocations have been as effective and efficient as we would like them to be. Making decisions about new projects, new programs. So that's the bottom line, is what kind of questions do we want to answer? What kind of decisions do we want to make? And then what kinds of data can we pull together and look at in a systematic way to be able to answer those questions? Program evaluation can be very broad. You can look at the entire population of publicly funded clients of mental health services within your county, or it can be very narrow. You can focus in on a specific funding stream. We can look specifically at prevention and early intervention funding. We can focus even further and look at PEI funding focused on the older adult population. So we can be as broad or as narrow as we want to be. We can look within funding sources. We can look at specific need-based populations, such as those with co-occurring disorders. We can focus in on, a lot of my work at CiMH over the years has been in the implementation of evidence-based practices. It's primarily been in children and family services. And the implementation of evidence-based practices has been accompanied by very rigorous outcome evaluation. If evidence-based practices have an increased level of scrutiny, right? People want to look at those more closely, which is interesting because we've already got scientific evidence that they work. But we're not being as diligent about rigorous outcome evaluation of our usual care services. And I think that collecting data and be able to describe all of the programs that we're providing and whether or not we're delivering effective, efficient services for our client populations is really important, be it in evidence-based treatment or usual care. It's kind of one of the flags that I wave everywhere I go. So as I mentioned, program evaluation, we can think of data in two different ways. We're going to look today at using existing data that's already being collected. There's a wealth of information out there. And we can also be very thoughtful on the front end in designing a new project, designing a new program, making decisions about a new funding source, and being thoughtful about new data that we're going to collect to be able to help us tell the story. When I think about the basic elements of a program evaluation or being able to describe a project, I want to know information in three areas. I want to know information about who I'm serving. If we have a program that is intended for a specific group, individuals with a specific set of needs, individuals of a certain age, and we actually look at the data of who's being served, do they match? Are we serving who we intended to serve? Does the program look as we intended it to look? If we have some assumptions in advance about the level of service we're going to be providing, about how many times we expect people to come to a group or to an individual treatment session before we start to see benefits. And we actually then look at the number of sessions or groups the clients participate in, the duration of services that they participate in. Does that look like what we expect it to look like? It's really important that we understand who we're serving, what services we're providing, but most critically, and I think what in our mental health field we haven't been focused on enough, is what benefits are we achieving as a result of those services? What kinds of outcomes are being gained? What kinds of improvements are being made in the lives of clients and families? So these are the three broad areas that I think program evaluation should focus on. I decided in presenting just a small number of concepts to focus on data quality first, and Herman already laid the stage for this with regard to ensuring that we're looking at and using data that are reliable and valid. Sometimes we have data available to us, and questions that we should ask are these reliable and valid data? I have a couple of graphics to help you think about, what is it that we're talking about when we talk about reliability and validity. So I have a ruler on the PowerPoint slide for reliability. Reliability is consistency in measurement over time. If I go into the fabric store and I want a yard of fabric, I'm going to get a yard of fabric at a fabric store in Phoenix. I'm going to get the same amount of fabric if I go to a fabric store in San Francisco. I'm going to get the same amount of fabric if I ask for a yard in San Diego, right? A yard is a yard. We have a very consistent way of measuring that. In mental health, things are a little fuzzier. We're not always consistent in our measurement. And these concepts come into play particularly when we're looking at selection of measures or tools, questionnaires to assess outcomes in our client population. But reliability could also extend to, let's say, the ways in which we're assessing certain demographic characteristics. Lots of times we describe our client population based on mental health diagnosis. If I were to put 10 clinicians in a room and have them interview one client and all come up with a mental health diagnosis, what's the reliability in their diagnoses? I'm not going to answer that question for you. I'm just throwing it out as reliability is very important, and it's consistency in our measurement. Validity is the ability to measure something that we think we're measuring. So I have a little sad face, little blue guy. The PHQ-9 is a very commonly used questionnaire to assess depression. It's used not only to evaluate outcomes of depression treatment, but it's also used to screen for the need for treatment. It's used to drive treatment planning. It shows whether or not clients have mild, moderate, or severe symptomatology. I can go on about standardized outcome measures all day. But one of the reasons that the PHQ-9 is so widely used is that it has been shown to validly assess this underlying construct of depression. So we might, with the best of intentions, want to include, say, a couple of questionnaires on an intake form to determine whether or not our clients are experiencing, let's say, problems with substance use or abuse. But the questions that we come up with are probably not going to be as good as validated questions that already exist in the field. And there's some, with that one example, there's some very brief, reliable and valid questionnaires that can be used. So always look to, for something that's already been developed that has reliability and validity. Sometimes if we are assessing something and we're not getting the outcomes that we expect, we should go back and question the quality of the data that we're getting. The quality of our interpretations, of our reporting, is only as good as the quality of data that we're collecting. So are we getting reliable and valid data? I say data always raises more questions than it answers. So one of the other sort of just basic concepts that I want to talk about today are different ways that data can be presented. And I'm going to talk about descriptive data, because descriptive data is readily available to you from a variety of sources. And I'm going to talk about descriptive data for numbers and for ways in which we categorize individuals. So first, numerical data. Numbers. Talk about age, duration of services, number of sessions. So these are, again, very basic concepts. Most of you in the room have been exposed to them before. Some of you may be experts in them. But these are common ways in which numerical data are presented. So usually we see the average, which is usually called a mean. It's just a fancy name to say it's the average, right? If I wanted to determine the average age of everyone in the room, I would ask everyone what their age is. I would add that up, and I would divide by how many people are in the room. It's an average. We see that all the time. But in addition to the mean, which is another fancy word for the average, there are two other common ways in which numerical data are described, and that's a median and a mode. So we often hear these three things together: mean, median, and mode. And lots of times you're given the mean, but you might want to ask, what's the mode? What's the median? And I'll tell you what those are. Median is, the way that I think about it is when you're driving down the road, there's a median that separates cars from going one way and the other. Your median separates your group right down the middle. 50% of people in your group will fall above the median and 50% will fall below. If we take the age example, we might, if we were to line up the ages of everyone in the room and separate by half, right, 50% above, 50% below, that number may or may not be the same as the average. This might be helpful if we want to start with a group of people for a particular intervention and divide them in half based on their, let's say, their scores on a specific questionnaire, or sometimes it might be age. Mode is the most frequently occurring number within that group or within that set. So it would be the most frequently occurring age in this room, which may or may not be the average. Sometimes the average, the mean, the median, the mode kind of cluster together, but sometimes they're different. I do a lot of work in outcome evaluation for children's services. And let's say I have a group of children that are entering a specific evidence-based practice, and their average age is 12.5. That sounds perfect to me because I want to implement a questionnaire that starts at age 12 and up. But if I delve into the data deeper, I might find out that the mode, the most frequently occurring age, is 11, which makes a large part of my group not eligible for my questionnaire. So I may want to make a different decision. So there are other ways in which other numbers that we can get that are simple descriptives of our data outside of the average that can help us to make decisions. I think it's always important to ask, what's the range? So in this case, the range would be the smallest, it's the smallest and the highest, right? So it would be the lowest age in the group and the highest age in the group. And I think this is really important when we're looking at, say, again, the use of standardized questionnaires are being implemented more and more, particularly as we in mental health services need to document the effectiveness, the outcomes of our services. So if I say that I took a class and I got a score of a 32, and I come back to this room and I say, I got a score of 32, you have no way of interpreting that. You might make some assumptions. Is that 32%? 32% doesn't sound very good. But if I tell you that the high score is 35 and I got a 32, oh, all right, pretty good. So knowing that possible range gives you ways to, a lot of information just to interpret what you're seeing in front of you. So those are some ways, descriptives for numerical data. Categorical data, what we're really talking about is ways in which we can group individuals, right? Gender, ethnicity, primary mental health diagnosis. And so what we do when we have categorical data is let you know how many are in that group and what the percentage is. And I'm going to show you a few different ways. We're going to focus on pictorial representations of graphical data as we move forward. But here is an example of descriptive data. And this is a table from one of CiMH's outcome evaluation reports. This is specifically for trauma-focused cognitive behavioral therapy, which is for children and adolescents who have experienced trauma and are experiencing post-traumatic stress symptomatology. And I just wanted to use this as an example. This is one table. It doesn't take up a lot of space, but it gives you a lot of information about who's being served. One of the things to note is that I tell you in the table header that the number of clients who entered is 18,815. But then if we start to look down at the data provided, if we look at age, our average age is 11. I'm not presenting the range, but someone might call me and ask. Happy to provide more information. But we have age on 18,650. So we don't have age on all the clients. And as a program administrator or a mental health board and commission member, you might want to look at the number for which you have a certain data point relative to the entire group. Do I have this indicator for the majority of clients, or do I only have this indicator for a subgroup of clients? And if data are missing, why are data missing? So in this particular table, I present, we've got one numerical data, so that's the average. And then for the two categorical variables, gender and ethnicity, I've got two groups in gender, right? Although actually we have added transgender to one of our outcome evaluation reports, so we now have 3 gender groups. For our functional family therapy reports, which we may want to extend statewide. Anyway, and I've got 5 groups in ethnicity, and some counties may have 20 groups in the race ethnicity category, but this is what is in this particular report. And instead of taking up more space with the missing category for those categorical variables, I've included a footnote. So another thing here is, we can look at data tables and it's just a bunch of numbers and it makes our head swim, but if we just take it one piece at a time, it really tells us a lot of information, and always look at those footnotes, because those footnotes are going to tell you information about what's in the table that you may not have known. And so in this case, I'm telling you, percentages may not total 100 due to missing data. And I'm using dates to calculate age. If I've got a data entry error in a date, can't get age. Anywho. Here are some visual presentations for data. So a lot of reports you'll see tables, and information in those tables can often be turned into graphs. I love graphs. It's a quick and easy way of seeing what's going on. So I'm just going to run through a few of them. The first one that you see on the left it's a representation, it's an example of a bar graph, and I've chosen to extend that example of the PHQ-9 because we are seeing its use more prevalent across the state. The x-axis over here, and you might not be able to see it from where you are, but I happen to know the range on the PHQ-9 of possible scores is 0 to 27. And so when I look at that x-axis, I know that it represents the entire possible range of scores. And what we're looking at then is a pre-intervention average PHQ-9 score and a post-intervention average PHQ-9 score. I can see it go down. One of the tricky things about this type of visual representation is if I change that x-axis, if I change it to, say, showing the difference between a 5 and a 20, my difference is going to look bigger. So I can make differences look bigger depending on how I adjust my x-axis. So always look at your x-axis, look at your range. Ask some questions. Is this the total range for what I'm looking at? Now, I won't go into the age example. Anyway, so that's an example of a bar graph. Bar graphs like this are usually used to represent, say, 2 points in time, as I am here, pre and post. Could also be used to represent, say, again, I work a lot in children's services, could be a parent report and a child report, and looking at those differences side by side. The next one that you see is a basic pie chart. We're going to spend a little more time on pie charts. Pie, just think of 100%. Everybody's got to be in your pie. If I were to take out 1/4 of my pie, that's a big chunk, right? That's 25%. We're going to spend more time on pie charts. But pie charts are used for categorical data. We could put gender into a pie chart and have 2 groups. We could take that data out of the table that I just showed you for ethnicity and move it into a pie chart, and I would have 5 groups. If I were an ethical reporter of data, I would have 6 groups and show you my missing pie piece. Histograms or frequency distributions, I think that this example gives a really nice illustration of the importance of not only knowing the average, but also knowing the mean and mode. So this specific example is one of the questions on the MISIP, satisfaction survey being used nationally. This is the access domain. The scores range from 1 to 6, and this shows every score that we got, and there are thousands of scores on the x-axis that goes up to 5,000. And what you might not be able to read down here is that the mean is 4.2. But when we look at the mode, the most frequently occurring score in the group, that also is right around this 4.2, but we have a second mode, something called a bimodal distribution. But it's important to look at our data graphically as well as in the hard numbers, because what we can see is that we not only have the majority of responses at about a 4.2, but we also have a lot of people who are endorsing that very high end of a 6. And I apologize that I can't remember if this is a positive access question or, anywho, ways in understanding data that are presented. So what we're going to do is we're going to take a couple look at some graphical representations of data. And I put this together a week ago, so I used the 28 registrants at that time. I'm going to go ahead and put this up while I talk about this. So I know that there are more people in the room today, so you might look at this and go, oh, I'm not represented. This is one of the, when we get to my last slide about context, the timing of data collection is critical. So here I am showing you data on the registrants in the room today, but I collected this data a week ago, so it may not accurately reflect the representation in the room. So something to keep in mind. So what I did is I just took everyone who was listed. I removed CiMH, I removed the planning members for today's meeting, I removed EQRO. And I, in my sort of naivete, didn't quite know what to do with Berkeley City. So, we have 58 counties and 2 cities, and didn't quite know what to do with them, and I'll talk about that as we move through the slides. And then I had one individual there was no county representation listed, so I got one unknown. So I'm going to show so one of the ways in which we approach the vast differences in needs in the state of California is to look at region and to look at county size. So those are 2 ways that I decided to break up the data of who's in the room today as of registered last Thursday. All right, so first I'm going to look at the registrants. So I had 28 registrants. All right, so we're looking at counts of people in the room. And this is how it breaks up by county region. Now, it was kind of an easy decision for me not knowing, really what to do with Berkeley City, because I know where Berkeley is. So I put Berkeley in the Bay Area. But I have this one unknown, right? So this is, in my pie, I am being comprehensive. All 100% of the registrants at that time are included. And I've only got one person that I couldn't classify by county region, and that shows up as 4% in my pie graph. But so you can see the distribution, and I'm not necessarily going to belabor the point. But these are registrants. LA is always called out separately, right, because they're sort of an entity in and of themselves. And we actually have 3 people that were registered last week for LA County. So LA County gets 11% of people in the room, or people who were registered last week, are from LA County. And you can see the Superior region, we have a smaller representation in the room relative to the other regions. Let's look at the data a little differently. This is representation of counties by region. So now every county only gets 1 count. And so at last week, we had 21 counties who were registered, right? This is a bar chart that we looked at before, but if you look at the x-axis, it goes up to 100%. And I've stacked my categories, right? So for every region, I can say, you're here, you're not here. You were registered, not registered. And instead of putting those in pie charts, I would have 10 or 11 pie charts to show the data in this slide, but I can stack them within each category and put them side by side and show a lot more information in one chart. So if we start over here on the right-hand side, we have 21 counties. Oh, right. 1 county didn't show up. So I don't have an other category. That would be a question that you would ask. Gee, up here it says you've got 21 counties represented in the room, and that says 20. That's a typo. That's an error. Anyway, we're just going with the point. We're sticking with 21 counties. So it's about 32%, right? So about 32%, again, this is a week ago, of all 58 counties in the state were registered to participate in today's data meeting. That's great. What do we want? We want representativeness. We want to be able to get this information out to everyone across the state. So let's look at our representation by region. If we were to just glance at this, we'd say, oh, wow, whoever that region is second from the right, they're great. They're all here. That's just one. That's LA, right? So LA just has to have 1 person show up and 100% representativeness. So one of the things to point out about interpreting a graph like this, when you have a benchmark, such as all counties on the far right, for all counties we're at about 32%. And then we can interpret the representativeness of each region relative to overall. So what we see is that the Bay Area and the southern region have a higher representation relative to the average, relative to all counties. They're at 50%, 65%. Not surprising given that we're in Irvine. Right? The central region and the superior region have a lower representation relative to all counties. Not surprising. All right, so now we're going to break it out by county size, and I am, sort of losing time here. But this is going back to registrants. So now my N goes up. I'm again counting every booty in a seat, or who I thought would be in a seat. This time what I've done is I've changed my unknown category to other, because I didn't know what to do with Berkeley City. Population-wise, I wasn't sure how they get classified with regard to, small, medium. I didn't know, and I had a limited amount of time to get my slides in. So if I had more time, I would have done more research. Anywho, what we see now is at 7%, and again, to keep in mind, 7%, we're talking about an N of 2. This is one unknown, and one that I just wasn't sure how to classify. But I know my data. And when you look at this, if you were to see that unknown, you might want to ask questions. Who is that? Why weren't you able to categorize that representation? And then I did the same thing with the counties. And this time my graph is right? But this is representation of counties by size. So again, our benchmark on the far right looks the same, because we have 21 counties out of 58, it's about 32%. But now look at the representativeness by size. Right? It sort of goes up with it as size of county increases, the representation in the room increases. If I were to do a targeted recruitment or a targeted distribution of materials from today's meeting, who might I focus on? Small rural, small, superior region, central region. All right, so the quality of data that you put out, your interpretations are only as good as the quality of data that are collected. So you always want to ask questions about where your data are coming from, how they were measured, are these reliable and valid measurements? Do I have everyone in the group represented, or do I have just a small percentage of my target group represented? Are my definitions the same from one place to another? Is a yard the same here? Is a yard the same there? And there are always multiple interpretations when we look at data. So we could look at those graphs and come up with what seemed to me to be some logical assumptions about why we have different distributions by county size or county region. But there are lots of interpretations, and getting people together in a room who have multiple interpretations and discussing those is really critical. And be very cautious when you're looking at small n's. Try to sort of pull that out with what we're looking at today. But if let's say I were to run a treatment group focused on depression in the elderly, and I have 4 individuals as part of my group. 1 week, if one person doesn't show up, that's 25% of my entire group. But if I'm running a group and I have 100 participants, I have up to 25 people that can't show up, that more flexibility for that 25% to be represented. So when we look at data, as you see, coming out of like the consumer perception survey, and you see percentages that vary, those small rural and small counties have really small n's, and 1 or 2 people can sway those percentages in really strong ways. A little bit of a tangent, but. In my early work with CiMH, I worked with the early first 5 agencies, and I like to steal their quote. They said, "No stories without numbers, no numbers without stories," and this drove all of their planning. We have lots of stories and anecdotes about the benefits of the programs that we are implementing. We have lots of stories and anecdotes about how beneficial a new program will be. But if we're not using data to drive those decisions, then we have nothing. Anecdotes in and of themselves are not sufficient. Data are critical, data are necessary, but in and of themselves, they're not sufficient. Both are necessary to make comprehensive decisions, to tell a complete story, and to make comprehensive decisions. data always raise more questions than they answer. We can answer very simple questions, like how many people attended a particular program. But why people finish a program, why people complete a program, or why people drop out of a program are very difficult to answer with data. And we really need to wrap additional information around those data elements. So the critical drive decision-making, but can't be considered in isolation. I already made an illustration of the importance to know the timing of your data collection. And because we're a large state, sometimes we're looking at data that's a little older. It's still important. It still represents our population, our communities, but we need to keep in mind when the data were collected. And of course, I'm not going to go through each of these, but and this is just a small subset of contextual factors to consider when you're looking at data and making policy decisions around data. And I have my contact information in the slides if anyone wants to discuss data more in depth. I'm always happy to talk about data. So, thank you. Should I see, are there any does anybody need any clarification, anything? I sort of sailed through it quickly. We were just going to kind of move on. You're going to be using some of these. Questions? Thank you so much. Yes.
I just needed a little clarification, maybe expansion on the PHQ 9. Oh. Hi, I just wanted a little expansion on PHQ 9. I just hadn't heard of it.
Oh, I'm sorry. The PHQ 9 stands for Patient Health Questionnaire, and it's got 9 items in it. And the PHQ 9 is starting to be used pretty widely across the state, particularly in our move towards integrated care. It's a quick, valid, reliable assessment of depression. It's been used in primary care settings for a very long time, but it's being used more increasingly in mental health settings. And there's also something called the PHQ-2, which is just a 2-item screener to see whether or not you need to administer the full questionnaire. But the PHQ-9 is also being used as a screening tool in some settings. I know adolescent, publicly funded mental health centers are using it to determine the need to funnel or triage adolescent clients into depression treatment programs. So it can be used to make decisions about treatment services. It can be used to monitor treatment over time and document outcomes. And it's a depression questionnaire. I apologize for not. Thank you.
Is it California or is it nationwide?
It's nationwide. It's available in a bazillion different languages. I can send you a website for it. It's in the public domain.
Hi. I was curious. I know that over the years, the past 10, 12 years, I've been involved in this, that the frustration, I'm on the QRC committee in San Diego, and the frustration has always been that the outcomes and how they came to the outcomes of one county is not the same as another county, and the definition of an outcome is not the same as another county. Mm-hmm. And a lot of these things can't, or it'll take a while for them to be similarized or equal. But how are we at doing that? That we can look at a data from one county and truly compare it to another county as being pretty much comparable.
Well, I think so. Being able to compare data across counties, but even also within counties across programs, is really challenging. And I think your point is in part because of the differences in definitions used or outcome measures being used. And I think we're really in our infancy at that comparability. There are some statistical techniques that can be used to equivocate data. You know, we can look at things like clinically significant change, reliable change, and these are some, some more complex statistical formulas. But I think, with 58 counties in California and 2 cities, we're doing things 60 different ways to a large extent. And I think that there's movement to try and have some standardization, have some consistencies. But those are challenging, right? Because we want autonomy to make decisions at the local level, but we lose the ability to compare because we don't have the statewide decisions. and I think there's a balancing act, and we're moving towards improvement in that area, but I think right now it's really challenging. And so even in Los Angeles County, I've been working with them on outcome evaluation for a while, and they're using the same measures across all of their programs that serve similar treatment targets, and even using the same measures, those are difficult conversations to have with regard to comparing the outcomes from one program to another.
And the other thing, as a client and consumer advocate, just like almost any business or any entity, when they're doing surveys or they're collecting data in that sort of way, there tends to be a higher percentage of negative. People take the time to make a negative comment more than they take the time to make a positive comment. That's
actually, when we look at consumer perception data and satisfaction data nationally, mental health services tended to be rated very highly. Perhaps it's if those individuals who take the time to not just answer the questions with set responses, but to write in their remarks, they may have had negative impacts or negative experiences with the service delivery system and want to explicate those.
And that was the other point, is that the access to getting to individuals when we have barriers like HIPAA and other things is hard to, at this point, get precise numbers that we really, really want to narrow it as much as we can, so then we can, treatment at some point will be individualized if we can get it clear enough, and the results will be amazing. So.
We have a lot of challenges. Again, I think it's a balancing act. We have to protect patient, and client rights and privacy, but it's really important to be able to share data among service providers. And, in California with citizenship issues, we struggle as well, and that, the need for documentation for some services. And I think we have a lot of struggles because we have more needs than we can accurately document and describe, and more benefits than we can capture as well, I'd say. I think Herman, and then I'll probably end because I'm over time, of course, I'm always over time.
When you started off your presentation and said you could talk about this for 6 hours, I said, yeah, right. But I would say, yes, you could talk about this for 6 hours. And I just
you don't want to hear it, but I can.
And I just want to say you made it simple enough for all of us to understand, so I wanted to give you some credibility for that. But I want to speak specific to my colleagues up in Superior County, like in Lassen, where it's hard for people to come. And I guess I'll address this to your boss and whatever. Are you, if Lassen wanted to have you come up and make a presentation of this nature, maybe expand it a little more, would that be possible?
We are always happy to provide technical assistance, and I don't really know the details about how we work that out. We understand why the Superior region is not as represented in the room as the Southern region.
Even though they think they are superior.
So we're going to do one more. We have time for one more question, and then we're going to move on. So was there a question here?
I just want to make a comment first of all. When nursing was concerned about its professionalism, I got a group together to look at diagnostic categories, interventions, and outcomes and categorize them. Perhaps something like that would be needed for us. The NIC-NOC-NANDA has been very helpful in terms of nursing research.
Oh,
so, and possibly could be used in this context if we were interested in doing that, because it's already set up.
NIC-NOC-NANDA?
Well, NANDA is,
I will look that up.
yeah. Look up NANDA first.
Okay.
And NIC and NOC are part of NANDA. Okay.
We
It's
love-
diagnostic categories for specific interventions, not medical categories, but interventions like on anxiety and so forth.
Thank you.
And it covers all of nursing categories, not just mental health. I had something else, but I can't remember right now.
Isn't it amazing how we live on acronyms? PHQ 9. NANDA. Okay, thank you all very much.